It's public responsible, I think. Yeah.
We're gonna get started.
Yeah, you should do it all the time here. Yeah.
So welcome everyone. It's lovely to see you all today. Nice to see wonderful snowy weather. So I'm really delighted to welcome you to the University of Ottawa, to the Faculty of Law. My name is Vanessa, the Center for Law Policy and Ethics here at the university. We're an interdisciplinary center, and we really promote bringing research and academics together with law policymakers. Just delighted to be here today to hear our speakers speak on a really important topic around. Before we begin today, I'd like to acknowledge the Algonquin and Anishinaabe peoples, who are the traditional owners and custodians of the lands on which we are today. And I'd like to pay my respects to the elders, both past and present, and acknowledge the contribution and sacrifice they've made to better our communities. Pass things over, and now Simon, she's the director of the Research and Education Center. Over to you to introduce our speaker.
Thank you, Vanessa. Bonjour à toutes et à tous. I'm a proper comment. Merci de l'intérêt à cette conférence. C'est heureux de nous associer avec le Centre de droit, politique et éthique de la santé et l'Institut de recherche LIFE pour présenter cet événement. Welcome and thank you for the interest in this Human Rights Research and Education Center, which is also an interest. We are very happy to be partnering with the Center for Health Law and Ethics, Vanessa Center, and the Life Research Institute, which is run by Nafisa Ishmael. So thank you very much. Our speaker today, Mary Helen McSweeney, is the 2025 Fulbright Canada Research Chair in Human Rights and Social Justice at the Human Rights Research and Education Center. She's an associate professor and program director, Master of Science in Health Science program at Houston University. In her graduate work, two masters, sorry, not LLMs, at Columbia University and a PhD at City University of Center. Her current academic work focuses on health, particularly in the areas of service delivery, long-term health care administration or long-term care administration, emergency preparedness, and population health management. She's also a fellow of the Chaire. She's published widely in her research. Today, she's going to be talking about chemical assistance in dying in Canada, provincial and Indigenous trends, and the human rights perspective. So I'll pass it over to you, Professor McSweeney-Feld.
So, bonjour, hello, Blachi. This presentation is bimodal and it's going to be recorded. Cette présentation est bimodale est en cours d'enregistrement. The lecture will be in English with summaries of key points in French. La conférence sera donnée en anglais avec un résumé des points clés en français. Et pour moi, c'est la première fois que je donne une conférence en français. Mon français est limité, mais je vais fournir un résumé des points clés en français. Si je fais des erreurs ou si je prononce mal quelque chose, je m'excuse. Aussi, il y aura du temps pour les questions à la fin. Si elles pouvaient être en anglais, ce sera utile. So this is a what I call content warning guidance, avertissement sur le contenu, because medical assistance in dying can be very controversial topic. It can also people's memories that may be upsetting. So I acknowledge that each one of you has come to this presentation with your own unique life experiences, which contribute to the way that you perceive information on a topic such as medical assistance in dying in Canada. MAID is a subject with content that could be distressing and could trigger memories for trauma survivors. If you're a trauma survivor and you feel overwhelmed or panicked during this presentation and find it difficult to concentrate, I encourage you to take the necessary steps for your emotional safety, which may include leaving the presentation if needed. A little bit about myself, first in English and then French. So again, I am the Fulbright Canada Chair in Human Rights and Social Justice. I'm Associate Professor and Program Director of the MS in Health Science at Towson University in Towson, Maryland, which is located close to Washington, D.C. And is actually right about 25 minutes outside of Baltimore City. I'm trained as a health economist, not as a lawyer or avocat. And again, as the introduction mentioned, I specialize in the fields of health administration and long-term care administration. I have additional training in public health and population health because of the type of program that I run. Also, I have lived experience in long-term care and end-of-life issues, and that was one of the reasons why I was drawn to this topic, because both my mother and my father passed away under hospice care. And I have wonderful things to say about hospice and palliative care. And then as medical assistance in dying has grown and spread not just here in Canada, but in the United States, I said this is something that really warrants more research, okay? I am married to a Canadian, and I have a home in Cape Breton Island near Sydney. And I also have family in Nova Scotia, in Ontario, and in Alberta. Okay. À propos de moi, je suis chaire de recherche Fulbright Canada en droit de la personne et justice sociale. Je suis professeure agrégée. Moment. Ça. Et directeur du programme de maîtrise en sciences de la santé, Université de Towson, Towson, Maryland, États-Unis. Je suis un économiste de la santé spécialisé dans les domaines d'administration de la santé et de la gestion des soins de longue durée. J'avais formation complémentaire en santé publique et santé des populations. J'avais expérience vécue en matière de soins de longue durée et des questions de fin de vie. J'avais une résidence sur l'île du Cap-Breton en Nouvelle-Écosse et famille en Nouvelle-Écosse, en Ontario et en Alberta. So, our time together, notre temps ensemble. I'm going to be providing an overview of medical assistance in dying in Canada, some history, quite abbreviated because it has become quite a popular topic these days. I'd like to discuss a little bit of the content of the 5th and 6th annual MAID reports that are published every year by Health Canada, and looking at issues of geography and MAID uptake, and possibly the effect of wait times for healthcare services on MAID. Also, I will be discussing MAID in Indigenous communities, some of the recent data that has come out there, but in particular, something that is a framework I first heard about in Sydney at Cape Breton University called two-eyed seeing, which is derived from Mi'kmaq belief systems. It is not Mi'kmaq exclusively, but it is derived from there, and its importance and how that kind of framework could actually be used not just for Indigenous MAID issues, but for MAID in general. So, dans cette section, je parlerai de l'aide médicale à mourir au Canada, aperçu Histoire et perspective provinciale, je vais examiner la géographie et l'adoption de aide médicale au mourir, ainsi que l'effet de l'aide d'attente pour les services de santé. J'examinerai également la manière dont AMM a été mise en œuvre, ainsi que les développements récents en matière de AMM. So, medical assistance in dying has been around for 10 years. Okay, the first legislation was passed in 2016. What is this? It's a health service delivered by provincial and territorial health systems as part of end-of-life care within a federal legal framework. So MAID is legal throughout Canada, but like many things in healthcare in Canada, it's up to the provinces to determine how they want to administer that, how they want to comply with the law. It sets out strict criteria about who can receive MAID and under what conditions. It's been allowed in Canada since 2016. It allows eligible adults age 18 and older in Canada to voluntarily request the service without pressure from others. That's a very important part of the MAID process. It has to be voluntary. You can't be coerced. There are 2 assessors that have to determine whether your request for MAID is appropriate given health conditions. And also, a person has to be given informed consent of all means available to relieve suffering, including palliative care. So not only is the person assessed, but as part of the assessment process, that person should be introduced and should hear about alternatives to medical assistance in dying, such as palliative care services, hospice services, etc. Okay? The original intent for MAID in Canada was to be a stringently limited, carefully monitored system of exceptions. Okay? Keep that in mind as we take a look at future slides. Health Canada produces a report every year. Okay? It's their annual reports on MAID. The 6th report just came out in December, okay, if I'm not, or late November. That is the most recent. It's publicly available. You can Google it and look at any of these reports, and there's lots of interesting information in it. And regulations for the monitoring of MAID were enacted in 2018. So there is mandatory data required for submission by practitioners, right? So if you provide MAID to a patient, typically you have to not only report to the province, but you also have to report to the federal government, right? So a lot of the data that we have from these annual MAID reports is the federal government data. Now, a couple of other things about MAID. There are 2 tracks for MAID. There's track 1 and track 2, okay? Track 1 was the first track that was put in place. That's actually where the bulk of the MAID cases come. Track 1 is for patients with a grievous and irremediable condition with a reasonably foreseeable death. In other words, a person that would have a terminal diagnosis. And in 2024, like in other years, 95.6% of the people and cases that are documented where we've had MAID have been track 1 cases. Okay? Average age, I'll also say, tends to be older in terms of people that are taking track 1. Track 2 was put in place in 2021. This is the track that has received the most attention, okay, and is the most controversial. So I'm sure if you've looked at any kind of recent publications and you see any kind of articles in newspapers or of wherever on MAID, it's typically something that's pertaining to a track 2 issue. These are for patients with a grievous and irremediable condition whose death is not reasonably foreseeable. And as you can see the difference, it's only 4.4% of people that took MAID in 2024. Now, in 2024, MAID provisions accounted for about 5% of all deaths in Canada and grew from by about 6.9%, say roughly 7% from 2023 to 2024. Now, the good news is compared to the pandemic years, as again, this has been out, right, for 10 years. If we look at MAID cases during the pandemic, the percentage of people taking MAID was substantially higher, double digits. So that's the good news, is that there are fewer and fewer people now who are considering this as an option for themselves. To back up that idea, the 6th annual report on MAID states that the annual number of MAID provisions may be stabilizing. However, they need more data over time to be analyzed for longer-term trends. Okay. Now, where does Canada sit globally? Because Canada is not the only country that has something like medical assistance in dying. There are many European countries that have had this in place before Canada ever had it in place. In the United States, we also have medical assistance in dying, but it's not a federal law. It's essentially a states' rights issue where if a state feels that they have a sufficient number of people that would like medical assistance in dying, and if the legislation can get through the state legislature, then it becomes reality. Right now, we have 12 states in the United States that have MAID, and New York State will be the 13th state, and that will go effective sometime this year. So it's a very small number of states in the US. Again, controversial for some states. Personally, I don't see the possibility of there ever being a federal MAID law in the United States, just because we have so many people and such differences of opinion in our states, right, that I don't see that as a reality. But certainly states' rights issue, yes. Now, where does Canada fall in all of this? It's viewed as having the second highest MAID rates in terms of percentages of deaths, behind only the Netherlands. Some people feel that MAID in Canada is too liberal. That's a matter of opinion, okay? And again, it's a controversial issue, so you have as many people on one side that are supportive of MAID as you have people with very strong opinions that feel that MAID is promoting suicide and is not a good thing to do, and then you have people in the middle, right? So again, some people will say second highest, that's a good thing, because now the message is getting out to people that MAID is available, right? There are other people who will look at that statistic and they will say this is not a good thing. So there's no real right or wrong answer in things like interpreting this information. So MAID's a federal law in Canada, but provinces can interpret and implement its provisions differently. That's very consistent with the Canada Health Act, right? So you have healthcare services, but it's up to each province to determine how they want to administer that, okay? So MAID deaths across Canada have grown by approximately 7% in recent years, but MAID deaths across provinces have shown some different trends. And that's where I want to just take a look at this is simple year-over-year percent calculations here that look at each province, right? The number of MAID deaths, okay, in years 23 and 24. You might ask why those particular years, because the years earlier than that, you were really coming out of the pandemic, okay? And this is the most recent data. So you can see at the bottom, right, 7% is the norm for all of Canada. But all of the provinces for which I have highlighted percentages, this is just a 1 year simple percent change, right? You can see some dramatic differences, right? In a lot of the Atlantic Canada provinces, Newfoundland, 33% increase. PEI, 22% increase. Nova Scotia, 19% increase. Alberta, 12.5%. Okay. BC, 7.9%. Why aren't the territories there? Because there weren't enough MAID deaths that could be reported, right? So typically, when you look at the MAID reports, you'll see things for Yukon, but not any, reportable numbers for the other territories. Okay, but I would say that's if you have 5 provinces that for 1 year, just 1 year, right, have double-digit for the most part percent changes, something is going on. Okay, now it could be that the word has gotten out that MAID is available and more people are taking it. It could be other reasons. We don't quite know. I'm just here to say this is what the data looks like. Okay, so people seeking MAID, okay, tend to not live in economically deprived areas. They tend to be educated, have high levels of income, okay? A lot of people will think, well, aren't a lot of people who aren't well educated, don't have a lot of income, who live in socioeconomic circumstances that are challenging, aren't they the people attracted to MAID? Not necessarily. And I'll also mention that is exactly the same trend that you see in many countries, including the United States. Now, could it be an education issue that people who are better educated and have more income, maybe more access to healthcare, are able to hear about MAID, have gotten some education about it, and then decide to take it? It could be, okay? We don't know for sure, but that's just what the data is telling us. Here's what's interesting, all right? We have the track 2 MAID cases, right, who have death that is not reasonably foreseeable. Track 2 MAID recipients tend to live in neighborhoods characterized by residential instability. They tend to live alone, and they may also live in a residential care facility when compared to track 1 MAID recipients. All of this data is out of the most recent 6th annual report on MAID, okay? Also, when we were looking at geographic perspectives, we just saw a chart where we're like, gee, MAID is really increasing a lot in the Atlantic provinces that tend to be more rural and have some real remote areas. Well, according to Health Canada, the vast majority of MAID recipients, this is when we look at Canada as a whole, not by province, do not live in remote areas and may not have a lack of access to healthcare services. So what's going on here, okay? I would say, okay, that instead of looking at Canada as a whole in terms of data, that what we really need to do is to drill down and look at various provinces and look at the differences there. And it's not the easiest thing to do either, because Statistics Canada has certain requirements in terms of data that you can look at. So for example, we saw the Atlantic provinces, right, with double-digit numbers, but the actual numbers are small. So for purposes of analysis, we may have to put all those numbers together and call one whole region Atlantic Canada in terms of doing any analysis. Now, this again just shows we just got through saying, gee, remoteness doesn't seem to have anything to do with MAID. And this chart came right out of one of the MAID reports from Health Canada. Purple is MAID recipients, green is population of Canada. I don't know about you, but I see some differences here, right? Newfoundland, okay, even just tiny, small differences here. In New Brunswick, 23% versus 22.8, okay? Even, Quebec, 3.7 versus 3.5, right? BC, 8.1 versus 7.4. I would say if you really looked at this, you would say, as a whole, Canada doesn't seem, to have remoteness as an issue, okay? But when you put all numbers together, right, and you have across all, the basic statistics, right, you may get one trend versus when you break it up by province. So I would say that there's something very different going on here if you were looking at the data on a provincial basis. So what are other things that could be affecting MAID uptake? Okay, and I had thought a little bit about this. There's a lot of, qualitative research that talks about, it's social determinants of health that are unmet, okay? And had some wonderful conversations with James Stomar, who's over at the medical school, who said, Mary Helen, there is no relationship that I can see between MAID uptake and unmet social determinants of health, okay? So I sat back and I said, he's been doing research on MAID in Canada for a long time. I looked at the literature and I said, maybe instead of socioeconomic unmet needs, maybe really what might be affecting this, and we don't know until we can really continue to do the analysis, it could be wait times for healthcare services. Again, another very popular, hot topic in the press, right? Now, in a socialized medical system, whether it's Canada, whether it's the UK, wherever it is, you'll have queuing and wait times are normal, right? So there's nothing bad about the fact that you have wait times, okay? You even have wait times nowadays in non-socialized medical systems, such as the United States, okay? But there's a lot of attention that has been paid to wait times because of provincial differences, okay? And there are various data sets, right? Ideally, the best way to do this analysis would be to go into province and actually look at their administrative systems and calculate the actual wait time, okay? But that's a very labor-intensive analysis, and it only applies to one province, right? So what happens in, say, Ontario, right, or Alberta or BC may not be something applicable to provinces in Atlantic Canada, right? But I had thought of this and I said, maybe there's an impact here. So Ontario, BC, and Quebec, according to the Fraser Institute that has the longest wait time database in Canada, they've been doing this for well over 20 years, if I'm not mistaken. Again, Fraser Institute's data is collected by surveying doctors, okay? So again, it is not from administrative databases, but it is longitudinal and it is there and it is publicly available, right? So you can see very large provinces have short wait times, while Alberta, Saskatchewan, PEI, and Nova Scotia tend to have longer wait times. So I asked the question, could wait times for healthcare services have an impact on an individual's decision to take MAID? Don't know, but it's a good hypothesis, okay? Also, those conclusions on remote residence, right? Remoteness has nothing to do with MAID uptake. Well, geography, right, might have and be impacted by wait times. Why? Because if you're in a more rural province, you probably have fewer healthcare providers that can service the needs of individuals. And so even getting access to family doctors, right, getting access to specialists could be much longer process than if you were in larger, more populous areas, like Ontario, as an example. So these are some of the research questions that I'm looking at, right? Could those conclusions on remote residents and MAID recipients be different if wait times for healthcare services were taken into account? So to use more of a public health epidemiology idea here, is that wait times end up being a mediating factor between your geographical location and the probability that you would take MAID. Okay? Interesting idea. That's the trajectory that a lot of my research will be taking. Now, if we want to put MAID into perspective, okay, the rollout of MAID in Canada took place behind closed doors. With conversations from physicians and lawyers, it excluded input from Indigenous communities. There's been a lot of attention paid to that and a lot of recent reports that have come out that have tried to address that issue, which I'll talk about shortly. MAID expansion to include individuals whose sole underlying condition is mental illness, in other words, those would fall under the smaller number of requests, the Track 2 requests, has been delayed until March 17, 2027. It's currently illegal. Now, again, that issue has been put off and put off and put off, right? Will there be a resolution March 17, 2027? I don't know, okay? Some provinces now are taking their own, perspective on this. There was an article in the Globe and Mail about Alberta's legislatures coming back, and one of the first things that they're going to be talking about is putting limits on MAID. Okay, particularly the Track 2 requests. Okay. Some people believe that the expansion of MAID under Track 2 is described as legislated ableism. The disabilities community is very, very concerned about there being a possibility of individuals being coerced to take MAID. Okay? It raises issues under the Canadian Charter of Human Rights and Freedoms by portraying disability as potentially worse than death. Right? So keep in mind, MAID is a human rights and social justice issue. Okay? And there are cases, right, that may come to the courts that are looking at this. Okay? MAID in other countries is viewed as a last resort option. Okay? And I would just say this, the rapid adoption of MAID in Canada, as well as other places, could be viewed in two ways. It's the success of personal autonomy by advocates for MAID. Some people would say, this is how the process should work. More information is coming out. There's absolutely nothing wrong with the statistics that you see here. Then there are other people on the other side who would say, oh, there's a failure in the social safety nets. There's a failure in terms of access to mental health services. That is a big issue here in Canada as well as globally by critics and disability rights groups. Now, other perspectives on MAID. Medical providers in Canada are required to discuss alternative available services to alleviate suffering for patients requesting MAID to ensure that it is considered a last resort. Are they? I would say the vast majority of doctors, if they are a MAID provider, they are raising this issue, right, with the people that they are assessing. Okay? There was a wonderful book that was just released called This is Assisted Death, and it was written by a physician who was reporting on their cases, their MAID cases. And what struck me, in every single case, they made it clear that they had that conversation. So it's like, great, it's being done the right way. Okay? This requirement, in my opinion, balances patient autonomy and self-determination with informed consent. Okay? And I would hope that that balance exists whenever anybody is assessed for MAID. Again, assessments and discussions on MAID should be conducted in a manner that is culturally appropriate, recognizing a patient's values, beliefs, and backgrounds. Is this really being done? Okay, remember, when MAID first came about, right, Indigenous communities were not included in that conversation. Maybe there are some initiatives to do that. We're not quite sure. We just don't have enough information to say yes or no. Okay? Again, are all MAID assessments done in this way? Could people be made shopping? What do I mean by maid shopping? Individuals that can't get approved for maid in their province go to another one for approval. Okay, there is an actual case, which I'll talk about. These are some of the newer things going on with maid. Maid transfers. Now, this is when a person is in a faith-based organization, requests for maid, and that faith-based organization cannot or will not provide maid. And so they then transfer the patient to an area or another organization, another healthcare provider, in order to administer maid. There's now a case in BC called Gay O'Neill et al. It seeks to end what's called these forced transfers and ensure that patients have access to maid in a non-painful manner. That case just came before the BC courts. I think that will go to the Supreme Court. My humble opinion, okay? But that's one of the issues. Maid shopping. There's a case here in Ontario of Keanu Vafian, okay? Individuals that can't get approved for maid in their province go to another one for approval. So Keanu is a relatively young man who had mental health issues as well as some physical issues, tried to get approval for maid here in Ontario, could not get approval, went to BC, was able to get approval, and took maid. And it is basically Keanu's parents, right, that are questioning, okay, should that have ever taken place, right? Should people, if they don't get approved in their home province, just go to another one and get the approval? Is there what I would call same-day maid, you know, within 24 to 48 hours? Well, here are some of the statistics in Ontario from a report that they issue. In 2023 in Ontario, there were 65 same-day maid deaths and another 54 the day after the patient was deemed eligible. Okay. There are certain provinces that want to limit maid. Alberta's a very good example. There are faith-based organizations that want their limits on maid. They don't want to be maid providers, okay? And so that's where a lot of the transfers come about. And again, in Quebec, there's the approval for advanced requests for maid that's also pending there. So there's a lot of unanswered questions about how we administer, right, this legislation. Okay? Now, something very interesting in Ontario. Ontario is the only province that has something like this, okay? A maid death review committee. In my opinion, personal opinion, I think that every province should have something like this, right? Provinces, by and large, there may be exceptions. I don't know the Canadian system as well as you do, but virtually every province that I've looked at, they have death panel reviews, okay? And these are basically experts who take a look at deaths from a particular condition or for a particular group of people to ensure that there was nothing, you know, that however the death took place, it was in compliance with the law. Ontario's the only one that does something like this, okay? It also takes a review of individuals with dementia that have maid. So there was a recent article done by an attorney, okay, Trudeau Lemons, who I believe is at the University of Toronto, especially for dementia cases. Now, this was a commentary article, right? But it was sharing their perspective, being a member of this committee, right? What did they see in the cases that were reviewed? There were cases where there was minimal capacity for decision-making and informed consent assessments, flexible interpretations of reasonably foreseeable natural death, waivers of final consent used as a form of advanced request for maid, and insufficient information provided by maid assessors on different approaches to end-of-life care. Okay? So this particular attorney is concerned. Okay? They're like if we're going to have this, right, this has to be administered properly. Okay? All right. Any quick questions before I go on to the... Yes.
There's been some cases, or the Keanu case, where they go to be.
Yes.
I thought that the criteria for people eligible for MAID was regulated federally.
It is,
So
but it's administered differently by province.
the criteria given by the federal government is not who can get MAID, but it's just the provinces have to administer this and then they can decide who gets.
Yep. And there appears to be a number of cases like this in BC. Okay?
People going to BC.
Yes, there appears to be. I'm not an attorney, but you can see that I'm very cautiously using my language. Okay, when we see those cases, BC seems to be one of the places that people go. Okay. Yes.
You said that according to your research, BC, Ontario, and other provinces, BC, Ontario, and Quebec,
Mhm.
they were the lowest numbers in MAID. That's what you said.
The
Ontario and BC and Quebec.
let me just go back.
Is the connection you made between the wait times and
Yes. Yes, they have the shortest wait times for healthcare services.
percentages of MAID are the lowest?
Well, well, not so much BC, okay? But relative to other provinces, Ontario and Quebec tend to, well, Quebec's got the largest number of absolute cases. But what I was looking at was the percentage increases. They tend to be, with the exception of BC, they tend to be more in line with what is happening on a national basis.
Because I was considering another factor. So the Ontario, BC, and Quebec
Mhm.
are the most popular provinces where immigrants are going in, those who are not born in Canada. Like in Ontario, I think 1 in 4 is not born in Canada. And
Mhm.
so that has an effect on that.
Culture, religion, yes, absolutely. Absolutely.
I'm curious to know if the age factors and age percentage of the populations have been taken into account. I know a lot of the maritime provinces are experiencing a larger
Yes.
rate, and if that plays into the higher percentage, and if that's taken into account to the stats.
Well, it's recognized in the statistics. Okay. It's in the reports, it's just a straight reporting of the data as opposed to relationships. But the vast majority of the cases are track 1, and the average age, the median age of people taking MAID is around late 60s, early 70s. Okay. And most of those people are end of life, okay, terminal illness, a lot of cancer patients, things like that, okay? Serious illnesses for which there's no cure, and some dementia as well. Okay. Yes.
Just curious about your hunches. Do you think the type of caregiver that some of these patients have has an impact?
Family member, not family member, culture, religious, yes. Yes, those are all going to be factors that will go into the analysis. Yes, absolutely, could be.
Where is that sort of going right now?
We are waiting for approval from Statistics Canada to get access to the MAID data. It is quite a process. Okay, including security clearances and because of the nature of what the data is. But once we get access to this, we want to wed the wait time, right, to the MAID data and then see if there would be any type of relationship. It would be hard to have real causal relationship, but we could do our best to say there's a measure of association, perhaps. I don't know. It's never been done, right? But we're hoping you know, that we would get some kind of good product from this. All right, let's move on to another topic of interest. Yes.
Any comparisons made with the Netherlands, because they have made much longer.
Yes.
Almost double.
Yes.
So, and we're second behind them in debt.
Correct.
If there's any comparative analysis we've done there of reasons why.
Not that I am aware of, but that would be a wonderful research topic. Okay, those cross-country types of analyses, I think are one of the future directions. Absolutely. Absolutely. Okay. So let's now look at medical assistance in dying in Indigenous communities. Okay. Le résumé, le nombre de personnes autochtones au Canada choisissant l'aide médicale à mourir a augmenté de 2023 à 2024, mais reste faible. En pourcentage de la population totale des communautés autochtones, le pourcentage de personnes recourant à AMM est comparable à celui de la population totale du Canada. Des études récentes publiées par des organisations autochtones et par Santé Canada ont tenté de recueillir les points de vue des autochtones sur les services de fin de vie et de AMM. La vision à 2 yeux est recommandée comme un cadre pour mieux comprendre AMM dans les communautés autochtones. So, en anglais, the numbers of Indigenous people choosing medical assistance in dying have increased from 2023 to 2024, but are small. Now, if you look at the MAID reports, it's only the 5th and 6th reports where any Indigenous MAID deaths have started to be reported, okay? They're small in number, okay? As a percentage of the total Indigenous community, the percentage of people taking MAID is comparable to that of the total population of Canada, right? So it isn't more. Recent studies, and there has been a lot of recent work, a lot of very important reports published in 2023, 2024, 2025, okay, that have attempted to capture Indigenous views of end-of-life services in MAID. And then there's something that I wanted to talk about called two-eyed seeing, okay? Right, so if any of you are familiar with Frankie Young, right? Frankie Young did her doctoral dissertation on two-eyed seeing. This is a framework that you hear a lot about in Atlantic Canada because it is derived from Mi'kmaq cultures and beliefs. It's not exclusively Mi'kmaq, but it is a very interesting framework that was referenced in a number of these recent reports as a good way of understanding MAID in Indigenous communities. So, Indigenous people choosing MAID in Canada increased. The absolute numbers were 144 in 2023, 164 in 2024. It's a 12% increase year over year, but it is a small number, okay? The only other data that we have on this is some breakdown by Indigenous group in terms of Inuit, Métis, and First Nations. But again, due to privacy and confidentiality, we really can't, get much further than those general categories. The proportion of Indigenous people taking MAID is lower than the proportion dying from natural causes, okay? Regional, provincial location, whether an individual lives in community or outside community, are factors that may affect Indigenous MAID deaths. And I just wanted to share a table with you. This again comes from one of the MAID Health Canada reports. This is just to show what some of the numbers look like, okay? But if you take a look at the proportion of MAID recipients who self-identified as Indigenous in 2024 and those dying from natural causes, you can see that it's a much lower amount. Okay, and people would view that as a good thing. But again, you can see a lot of variation in here. Okay. So the need for Indigenous peoples across Canada to have equal access to high quality palliative care and MAID has been stipulated by both Canada's Truth and Reconciliation Commission and the UN Declaration on the Rights of Indigenous People. So again, this goes back to the idea of MAID being a human rights and social justice issue, okay? But as I said earlier, Indigenous peoples were not part of the original conversation on MAID back in 2016 when the law was put into place, right? So the Congress of Aboriginal Peoples Palliative End-of-Life Care and Medical Assistance in Dying Project was conducted in 2023 to 2024, okay? And they have issued a report of their activities. What they had in mind was to develop an Indigenous palliative care framework in conjunction with Health Canada, engage their community to develop policy considerations around MAID, and to develop educational materials for healthcare providers and community members. Okay, so after that report, there then was a December 2025 report just published by Health Canada called What We Heard, right? That was a lot of the recommendations, right, in the Congress of Aboriginal Peoples report prompted the content of what you see in the December 25 Health Canada report. It summarizes discussions with many First Nations people, Inuit and Métis, okay? So there are a couple of key themes here, okay? People sometimes, when they look at Indigenous communities or communities of color, they think that everybody thinks the same way, and that is not, absolutely not the case. So what came out in this report, I would say, is very consistent with that. There are three broad views on MAID in Indigenous communities. There are those that are open to MAID, there are those open to MAID under certain circumstances, and then there are those that are opposed to MAID due to cultural, spiritual, ethical, or systemic concerns. Remember that suicide is still a big issue in Indigenous communities. And so even the discussion of MAID prompts concern, right? What are we doing? Are we legitimizing suicide when we have so many, people, young people in particular, who have considered suicide as an option? Okay, so it's that's where the systemic concerns come into place. This report also said culturally safe and holistic care is important. Access to health and social supports is needed, especially in more rural, remote, and northern areas. If you want to develop MAID policies and palliative care policies, whatever takes place has to be in very plain, easy to understand language. And this is going to be something that will continually evolve, right? It will be one where you'll have to have collaboration with people that are outside the community, okay? And that's where Iptuapmunk, two-eyed seeing, okay, that framework comes up in these reports as being used to summarize community member perspectives. So what is this? Has anyone ever heard of this? Okay, so I have at least one nodding head. It is very popular, and it's something that you do hear quite a bit in Atlantic Canada, probably because there are so many Mi'kmaq reserves that are there. But two-eyed seeing has been around since, at least in terms of publications, since 2009. It was a framework developed by Elder Albert Marshall and his wife, Dr. Merdina Marshall, okay? Dr. Elder Marshall is still alive and well, okay, and lives in the Eskazoni Reserve in Cape Breton Island. Merdina has since passed, but they did a seminal article, okay, in 2009 that introduced this idea of the two-eyed seeing framework, okay? It is not Mi'kmaq law, it's derived from it, okay? It was derived from it because the Marshalls saw a need for Indigenous communities to be able to communicate and talk with Western medical communities and other communities, right? Two-eyed seeing is used a lot in environmental work as well. It's an adaptation for how Indigenous ways of knowing can be bridged with other knowledge systems. So what is two-eyed seeing about? Well, again, think of a person's face. You'll see a diagram shortly. It means that one eye, right, has the Indigenous ways and beliefs. The other eye has the Western ways and beliefs. And when you view something, you should view it from two of those viewpoints. Okay? Culturally safe care can be supported by two-eyed seeing because the approach brings together the Western way and the Indigenous ways of knowing. Okay? Now, again, why is that important? MAID really is a Western concept. So if you're trying to introduce a Western concept, right, to an Indigenous community, you have to bring in, Indigenous beliefs, ways, and the community, right? So that's why two-eyed seeing is such an important framework for people to know about. What does that look like? Something like this. I mean, there are varying, diagrams, but this is really that one eye sees from the Indigenous perspective, the other eye sees from the Western perspective, and you can see the interlinkage between the two. Okay? Now, how could this be applied to medical assistance in dying decisions? Okay? Again, Frankie Young and I had a great conversation about this. So this were some of the ideas that came out of that conversation. Two-eyed seeing requires individuals to look at their own laws and values in their community before they make decisions like MAID, okay? Individuals in Indigenous communities can't make a decision just on the basis of a concept that comes out of the Canadian legal system, okay? They have to consider the principles of their Indigenous community, okay? It brings balance to MAID decisions. It requires addressing any issues affecting an individual's social needs as well. It does slow down the decision-making process, right? Because if you have to think about what is it in my culture, my belief system, okay, that would apply to medical assistance in dying decision, okay? Could this be a helpful framework in making other types of MAID decisions besides just for Indigenous communities, right? That was my aha moment here is this is something that could actually be applied generally, okay? That one eye looks at that person's culture, belief system, religious traditions, right? And then the Western Canadian legal side, healthcare system side, and bringing those together, that perhaps is that a good way of making decisions about MAID? Okay, so what have we learned today? MAID's a very complex issue. There's a wide range of individuals supportive or opposed to the legislation in Canada, and I don't think that will go away anytime soon, okay? MAID definitely is a human rights and social justice issue, okay? Now, a lot of the research on MAID that's been done so far is qualitative research. So it's going out into communities, interviewing people, and then coding those responses, seeing the trends, and then reporting. That's great, okay? It's a start. But again, qualitative research, you're recording people's opinions, right? I think it's time now for people to start to take a look at the data that is published in these MAID reports, okay? And to really look at trends and think, hard about what are the factors that really affect the MAID decision, okay? So that's why the work that I would like to do talks about the quantitative data, okay? Indigenous views on end-of-life and MAID are definitely important, and resources to develop end-of-life education and services in Indigenous communities are absolutely essential, okay, because they were excluded from the original conversations. Okay, and the two-eyed seeing, that's why I wanted to talk about it, is, in my opinion, a tremendous contribution to this whole issue of MAID. It may be a way that revolutionizes, it may slow down the MAID decisions, right? But if you're using two-eyed seeing, okay, as a framework for introducing a person's culture and belief system with the Western law, right, that might be a good way to look at things, right? So if you ever have an opportunity to listen to Elder Marshall, he is a phenomenal speaker, has a lot to say about this, and very wise man. Okay, so I want to say thank you. Thank you to the University of Ottawa for bringing me here as a Fulbright Canada Scholar. There are some people who've really helped me in terms of refining my ideas on MAID research. James Downer, who's University of Ottawa Medical School faculty, but also over at Ottawa Hospital. Jonathan Patrick is over in the Telfair School of Business. Frankie Young, who is on the in the law school here, I guess has moved on to other places and other pursuits, and others that I've talked to, okay, who've helped for ideas with this presentation. Certainly the staff at HEREC, the Human Rights Research and Education Center, this wouldn't have been possible without their help. The Life Center also helped to promote this event, and I thank them for doing that. And if you would like to contact me further, my contact email back in the States is mcsweeneyfeld@towson.edu. And these are some selected references. There are a lot more than that, but as you can see, there's quite a lot that's being developed here. And any questions?
Thank you so much. Have time for some questions?
I think there's somebody to ask. There's.
Oh, I'm in the chat? Okay.
Joe.
Okay, we can, okay, so maybe we'll start with you first.
Yeah, this is a hypothetical legal question, but it could happen in reality. Say, for instance, as mentioned, here, what we call it track 2 MAID, it on psychiatric disease, psychiatric illnesses, legal in Ontario, but they are reviewing it to 2027. Say, for instance, in some places in Europe, it may be legal. And say, for instance, if a physician qualified in Ontario, he is going to work on a contract in Europe. And he does something like he comply with the request made, track 2 made. So once he comes back to Canada after the contract, will he be, is he facing something like a persecution or a disciplinary action?
I am not an attorney, so I will defer to the attorneys in the room, okay? But I'm assuming that legal system is one country's legal system, and
Yeah, but on the other hand, like some people, Canadian tourists going to the other countries, abusing kids, once they come back, they could be persecuted. It's not, that's what I was going on that basis. You are talking about jurisdiction, yes. Legal system is for one jurisdiction, but sometimes extra jurisdictional issues. It may be like this, so that's I was wondering.
That's
fine, yeah.
I don't have the legal expertise, so I'll defer to the lawyers in the room on that. But I would say track 2 has a lot of the difficult, deeper questions, okay? And what I see happening is that there will be issues that will be going to the Supreme Courts, okay? And I would really say I would rely on their guidance in terms of what their decisions would be, okay? And then I think I would be able to say more about what track 2 is, what Canada wants it to be, okay? Which I think is very important. We could have a more liberal interpretation of track 2 than most countries, but that may be what Canada is looking for. Okay. Other questions?
Just out of interest, is there a Canadian or a provincial forum for the dissemination of the results from research? And if so, or if not, how does, what is the sector in the health conferences that MAID would fit in?
It's an interdisciplinary issue. It could be research that could be discussed at a legal conference as much as a gerontology conference or a health services conference, depending upon what lens. I do know that there is a brand new journal that is out that is devoted to publishing manuscripts on research related to MAID. Okay. A lot of the MAID research, if it's not governmental reports, then you see it in anywhere from legal journals to what I would call health services research. So it's all over. Okay. But yes, I mean, there is a whole association of MAID conveners, and they meet on a regular basis and discuss issues. Now, in terms of whether that's more research oriented, I think it's more a forum to help the conveners who are the people making the tough decisions. Okay.
I think you had a question too, yeah.
Yeah, I just have one question, or I have a few, but matter. I was just thinking about the Supreme Court, like potentially going to the Supreme Court. You discussed charter violations. In that case, whether they were to rule like blanket statement against the prohibition of MAID, it could be seen as a violation of Section 7, like liberty and security. I guess prolonging suffering or not giving people an option other than suffering could be a violation, but the reverse is also true. Like giving an option could be also a violation of Section 7 as well. I'm just.
You're seeing the complexity of the issue.
Yeah.
And I would basically say if cases were to come before the Supreme Court, I look forward to seeing things like that to clarify, okay, where MAID fits in the legal and legislative process of Canada, because I think it would help a lot of other countries as well. Okay. Yes.
My question pertains to essentially the trust of Indigenous communities in Canadian medical systems and how that might influence whether they're open to maybe even if they do take on the two-eyed seeing approach, because
I think it will depend upon each community. And that's why I think that data that you have a third, and a third, you have ones that are open, ones that are okay if we put certain guardrails, and there are ones that no way. So it may be each community decides to go its own way. And some may say for our community, this is not the way we want to go. And then there are others. Somebody had shared with me recently that there are some Indigenous communities that have had, I believe the Inuit have had an idea like MAID, in terms of their belief system. So everything, it really depends. As I said, there's so much diversity. And that would be a good thing, that as various communities choose different pathways to share that and to also share those outcomes, okay, and how the conversations are handled and presented, how MAID is convened. The more data that we can collect, the better. So I would say you're going to see a lot of diversity. Any other?
Sorry, just one more question. You discussed statistics about age, culture, population, and socioeconomic status.
Right.
But is there any about gender, like related to whether women or men would take MAID or?
Women tend to live longer than men. Okay. So I would suspect, I would have to go back and double check, but women do live longer than men, so I would not be surprised if more of the deaths might be female as opposed to male, just because women have longer life expectancy. Okay, so that would be more a demographic factor that would be affecting that, as opposed to gender viewing made in one way versus, you know, people of other gender viewing it another way.
We'll take some questions online now.
For you, in countries with track 2, is there data that shows a correlation between rates of track 2 requests and disabilities, poverty?
I will do some hand waving here, that my knowledge is really confined right now to the US and Canada. Okay, US has nothing like track 2 at all, and most likely will probably not have track 2 either. I don't know.
And the second one, have you reviewed marginalization data for track 2 made? There are clear red flags in the Health Canada data. It may be worth flagging that Dr. Downer is associated with dying with dignity, so
Yes.
may not be the most impartial.
Got it. This is one of the issues that you have in terms of doing MAID research to keep it balanced. That's a very good point, okay? And we are trying to keep it balanced by having some of the moderating factors in the research being certainly religious affiliation, okay? But yes, what I've tried to do is to do literature searches that are balanced, that looks at both sides, okay? Good point, though.
I have a question here.
Yes.
About, you mentioned quantifying the qualitative data essentially, and because MAID is such a personal, individualized issue, it's like that. I'm curious to know how you plan on quantifying, if it's even possible.
Well, again, in the best of all possible worlds, the best way to wed quantitative data to qualitative data would be mixed methods research, okay? But then you have to set up your research to do something like that, okay? These are secondary data sets, so it's hard, you know, to do something like that. I'm just saying that looking at what the numbers are telling you in the MAID reports is really important now, okay? And that overall trends for Canada may not necessarily apply to other regions in Canada, okay? And that kind of differential, those differences need to be brought out in research.
There's another question online if you want to.
Sure.
So a greater percentage were women, 56.7%, while 43.3% were men. This represents a small narrowing of the gap between women and men when compared to 2023, when 58.5 were women and 41.5 were men. This is also consistent with overall population health trends.
Yeah.
Where women are more likely to experience long-term chronic illness, which can cause enduring suffering, but would not typically make a person's death reasonably foreseeable.
Yes. Thank you. Absolutely agree. And those are trends that we need to keep looking at as well. Remember, we've also have demographic cohorts. We have baby boomers. We have, you know, that are well into the aging of the population, turning age 65. And now we've got the generation in back of them that may have entirely different views on this. But whoever said that, thank you. Okay, that's a very, very good thing to point out.
I also had a question. I was wondering, so we saw that in provinces where the absolute number was already high, the increase in percentage was smaller from from in this past year, and whereas in provinces where the absolute number was lower, the percentage was higher. And I'm wondering if you were to interpret that, are you seeing like provincial differences in track 2 versus track 1? Do you think one is expanding more in certain province?
Again, one of the problems, and remember that those were just the absolute numbers. They weren't, done as a per capita number, so you could have different results there. In terms of more track 2, I would say Quebec, certainly, just because of the legal structure and more permissiveness, and more permissive, I shouldn't say permissiveness, permissive interpretation, okay? You may see that. Certainly British Columbia, and that I can see, but the tough thing is there aren't a lot of people in track 2. So it's hard to make those connections. You can make them just from the types of legal cases that you see, that there are so many cases that seem to be pointed at BC, or questions the fact that Quebec is trying to struggle with, what do they really want to define track 2 to look like.
Thank you so much, Mary Helen. Sure. Any final question? Yes.
One more question, quick question. This is about the certificate of death and the cause of death in the certificate of death. I think I have read somewhere that if it is made death, so it goes always for privacy reasons, that it goes as death under natural circumstances or natural causes. Usually when you say natural circumstances or natural causes, that means the person aged and died. There's no distinguish between these two.
You've raised a good point, okay? Because let me take Nova Scotia as an example. In Nova Scotia, effective January 1st, 2024, doctors are no longer required to put MAID on a death certificate. In fact, they're encouraged not to put on MAID on death certificates by the Medical Association, okay? And now, what's interesting there in that model, okay, so if you're a MAID convener, you report that the MAID death has taken place on a federal level, but the death certificate doesn't have that information on it, okay, as of January 1st, 2024. There are provinces where you have to put MAID on the death certificate. Nova Scotia is not one of them, and I think it's either Saskatchewan or Manitoba where also there isn't a requirement. So that is another issue in terms of being able to even do these quantitative analyses, okay? Because you would want, in terms of tracking the number of deaths, the death certificate is the most, logical place to do this. But you may not necessarily have that death recorded there. That's why these annual reports and the federal data is so important. So I'm not saying that the MAID death isn't reported, okay? It may not be reported on a provincial level. Nova Scotia did this for a reason, okay? They felt it was a privacy and confidentiality issue. They were concerned that they heard from people that they didn't want MAID on their death certificate, okay? And that they were more open to having MAID if a natural cause of death or some other cause of death other than MAID did not appear on the death certificate. Maybe they were concerned that they didn't want family members, or anyone else who would look at the death certificate. So yes, that is one reason why it would be very, very interesting over time to take a look at Nova Scotia and see, have the MAID deaths gone up? Because that was the reason that they wanted to do that.
But the death certificate will compulsorily must state the cause of death.
Yes.
Compulsory.
Yes, but they, as I said, in Nova Scotia, they feel that it could be another diagnosis, but if it was made, right, that was convened, that information goes to the federal government.
So I was curious that if the deceased has committed suicide, what does it appear on the death certificate as the cause of death?
That I don't know.
So with that, we'll conclude. Professor McSweeney, on behalf of Penelope, Vanessa, myself, and the centers and institutes that we direct and the participants, we would like to thank you for this very insightful presentation.
Thank you.
We learned so much about a topic that is really controversial, but this was very, very. So thank you for your time and for sharing your expertise with us.
Thank you.